Hey, what's up, everybody? Forget it. I cut it off short because I noticed that there were some people that were dropping off of the stream. And you know what? If 5 minutes is too long for a little intro, then so be it, right? Hey, what's up? My name's Sean. If you are new here, welcome to the FlightCrit community. I do broadcasts similar to this on a semi-regular basis, hopefully more often. And what I'm going to actually be talking about for probably the next 15 minutes maybe is ischemic strokes in the transport world, pre-hospital and transport world. I'm a critical care flight paramedic here in Colorado. I run FlightCrit along with my team, and we like to do broadcasts like this just to kind of give people some education. So what we're going to be talking about today, like I already said, is ischemic strokes in the pre-hospital and transport environment. A lot of this information you may already know, some of it you may not. Good review, good information for those of you out in the field. So let's get going. All right, here we are. We're going to be talking about ischemic strokes. So the big thing that I really want to kind of share with you is just kind of like some information about how we manage these patients prior to them getting to the definitive facility, right? So ischemic strokes, we all know it's an obstruction of blood flow. Might be from atherosclerosis, might be from a plaque emboli, could be from a clot embolism. In any case, we need to identify these patients quickly and we need to get them to the most appropriate facility for them to receive definitive care. Let's think about time frame for a little bit, right? We used to think of these patients as if we didn't see them develop their symptoms, or if a family member didn't see them, witness them develop their symptoms, if it was like a wake up type stroke where grandma is found first thing in the morning with stroke like symptoms and nobody knew the time of onset, she was pretty much hosed. We sent them to a rehabilitation facility and she lived out the rest of her days with whatever deficits she had. Not necessarily the case. We can anymore. We do thrombolytics, thrombectomies, and the evidence is consistently evolving for what is the best way to manage these patients. Right? So just a quick little review. We got all kinds of cerebral arteries. There's the basal arteries, the anterior carotids, middle cerebral arteries, etc., etc. Terms that you will hear are large vessel occlusions and thrombectomies, and who is a candidate, right? Look up what the large vessels are. It's like the basilar artery, the internal carotid, and the middle cerebral arteries, as well as some others. But you really don't need to know about that. What you need to know is how we're going to manage these patients, all right? So, quick question for you. What is the upper time limit for receiving TPA for ischemic strokes? Is it 3 hours, 4 hours, 4.5 hours, 24 hours? If you're watching, put your comments in the put your answer in the comment section below, and we'll talk about that as we go through the lecture. Okay, so when we've identified a patient who is having a potential ischemic stroke, we need to manage their blood pressure. If we do not know what type of stroke they're having, right? We pick them up out in the field, EMS gets called, 911, do a Cincinnati Prehospital stroke scale, and they have positive stroke symptoms. Maybe they do NH, maybe they do MEN, doesn't really matter. There's all kinds of scoring systems out there, but they have a positive exam for stroke-like symptoms. Our goal is to keep their blood pressure less than 220. If you're doing an interfacility transfer and you've identified, or the patient has been identified as having an ischemic stroke, we need to keep a different set of parameters, right? So if the patient is a candidate for TPA, the blood pressure goal that you need to shoot for is 185. They have to be less than 185 in order to receive TPA. Once they have received TPA, their blood pressure goals are 140 to 180. Okay, very important. If it's a hemorrhagic stroke, the blood pressure parameters are different. We'll talk about that in a later broadcast. So less than 185 in order to receive TPA. That is a very common question that you will get on your board exams. That is also a very common question that will come up during interviews. They'll give you a scenario. Patient has a blood pressure of 195. Can this patient receive TPA? The answer is no. They might then follow that up as, okay, well, what blood pressure, or why can't the patient receive TPA? And what blood pressure does the patient have to have in order to be a candidate for TPA? The answer is less than 185. Once they receive TPA, the answer is 140 to 180. Why is that? It's a thing called hemorrhagic conversion. Okay, you've got a weakened blood vessel. Now you've opened up that artery. You are now introducing blood through or into that vessel that has been ischemic, potentially weakened, and we don't want that blood vessel to then rupture. Called a hemorrhagic conversion. Now the patient's got a bigger problem. All right. So management, rapid identification and transport. Here's the answer to that question. Typically, it's been 3 hours from onset to receive TPA. Some stroke centers are pushing that out to 4.5. So the correct answer to the question that I posed before is 4.5 hours. Okay. Now, if you said 3 hours, you're probably just fine. But in reality, most stroke centers, most comprehensive stroke centers, are saying you can go ahead and give the TPA out to 4.5 hours. Okay. Beyond that, our goals are pretty much the same as we've always heard. Protect the airway, optimize oxygenation and ventilation, support their blood pressure. Okay. So, thinking about how we identify these patients, a head CT must be negative. If a head CT is positive, that means there's blood in the cranial vault. That would mean that the patient is not a candidate for thrombolysis, right? So we've heard this before, right? They take the patient to the CT scanner, they got a negative CT. Is that good or bad? In the case of a patient who's presenting like an ischemic stroke, that's actually a good thing, right? We want the patient to have a negative head CT because that tells us that there is no blood in the cranial vault, so meaning that they've had a hemorrhagic stroke, right? So negative CT does not rule out a CVA; it just rules out hemorrhage. Blood pressure must be less than 185 over 110 in order to get TPA, right? So mechanical thrombectomy. This is another thing that they will do for these patients. If the patient is a candidate for thrombolysis, they will give the thrombolytics and then still request transport to a comprehensive stroke center where they can then go in and perform a mechanical thrombectomy. Mechanical thrombectomy is where they actually go in with a coil and retrieve that clot. Now, if the patient is less than 6 hours, they'll do the TPA. Otherwise, they will just simply transport the patient for mechanical thrombectomy. Okay. Now, you might get called, to do this transfer, and you might say, well, wait a minute, this patient's outside that range, right? They're outside the range for TPA. It's greater than 6 hours. It was a wake-up stroke. This is why you're getting asked to transport this patient, because these studies are showing that even patients out to 24 hours with mechanical thrombectomy still have good outcomes. So don't delay transport just because it might have been 12, 18 hours since the patient's onset of symptoms, okay? The other reason they'll do this is for what I describe here as infarct size mismatch. The patient is showing signs of either a very small infarct, but with really drastic neurodeficits, or the opposite, right? There's some kind of mismatch there. They can go in and identify doing certain types of scan, specifically what's called a perfusion scan, and they'll actually see how much of the tissue around that infarct is actually dead tissue, and then decide whether or not it's safe to go ahead and perform that mechanical thrombectomy, because like I already said, we don't want the patient to convert to a hemorrhagic stroke. All right, so TPA. I'm going to go ahead and lyse this clot. The only accepted, or I shouldn't necessarily say the only accepted, but the number one, the primary treatment for ischemic strokes is alteplase, or TPA. There's some studies looking at the use of TNCase, which we generally associate with MIs. So the evidence is changing, but right now the primary thrombolytic that they are using for strokes is TPA. The dose of that is 0.9 milligrams per kilo to a maximum dose of 90 milligrams. Now, the bottle, or the way it's supplied, is in a 100 milligram dose. So the best practice is to make sure that whoever you are picking that drug up from, sending whatever the sending facility is, ask them if they have removed that excess amount. So 0.9 milligrams per kilo up to a maximum of 90 milligrams. The first 10%, so 9, if you're giving the maximum amount of 90 milligrams total, 9 milligrams will be given as a rapid bolus. That leaves 81 milligrams left over. That will then be run over an hour. Really easy math. It's 8.1 mLs per hour. I'm sorry, 81 mLs per hour, because the concentration is in a 1-to-1. Once the TPA is given, you must keep that blood pressure less than 180 over 105 for 24 hours. I've already said this multiple times. The risk is hemorrhagic conversion. So, goals: rapid identification and transport to a facility capable of CT, blood pressure control, preserve and support CPP while minimizing complications. If you remember, cerebral perfusion pressure, CPP, is equal to MAP minus ICP. You're not necessarily going to know what their ICP is, so just expect to try and maintain a mean arterial pressure somewhere in the vicinity of 85 to 90. Target systolic blood pressure is 110 over 140 for this is hemorrhagic, intracerebral hemorrhage. Okay, ICP control, anticoagulation reversal, surgical evacuation of the blood as needed. That's all we're going to talk about today. Remember, I just wanted to talk about ischemic strokes, what our goals are. The next step is hemorrhagic strokes. How do we manage those patients? We'll talk about that in another broadcast. This was just kind of a touch on ischemic strokes. Remember, rapid identification, rapid transport to a facility that can do a CT. The CT is a non-contrast CT. We want it to be negative, which means there's no blood in the head. And then they will make the determination based on the thrombolytic checklist as to whether or not the patient is a candidate. If they are a candidate for thrombolysis, they will give TPA 0.9 milligrams per kilo up to a max dose of 90 milligrams. You give 10% of that as a rapid bolus, the remaining 90% over an hour. Transport the patient within 24 hours of symptom onset for mechanical thrombectomy. Doesn't mean they'll always do it. Even if the patient is not a candidate for TPA, it will still transport within that 24-hour window for mechanical thrombectomy. Your blood pressure goals for managing these patients is systolic blood pressure less than 185 to receive TPA. Once they have received TPA, your blood pressure goals are less than 180. Remember, we need to keep these blood pressures high. So if their blood pressure is less than 140, we need to be starting some kind of pressor. Usually it's neosynephrine in order to keep their blood pressure high in that 140 to 180 range so that we can try to perfuse past that blood clot and prevent the blood or prevent that penumbra in the area around the blood clot or the infarcted area from getting worse. All right, maintain your blood sugars, maintain normothermia. If you have any questions, put them in the comments below. That's all I got for right now. This is Sean. Thanks for watching. We'll catch you next time.